Okay, great. Thank you very much. That's it then. We can move on to our expert panel. So we will have everybody introduce themselves one by one here. I think it's the best way. So we'll start with Dr. Chang, who I will send live. Go ahead.
Hi, my name is Genevieve Chang. I'm one of the obstetricians that do deliveries here at Southlake. I'm the chief of obstetrics.
That's great. So we'll go to Dr. Nathanson next.
Hi, I'm Barry Nathanson. I head up the medical ICU here at Southlake.
That's great, thank you. And then we'll go to Dr. Wulffhart.
Hi, Zaev Wulffhart. I'm a cardiologist, electrophysiologist, and the physician leader of the regional cardiac program. Hi.
Okay, that's great. We do have Dr. Van Schaik on the call as well. And we are waiting for Dr. Thorne, so hopefully he is here shortly to answer any rheumatology questions, but we will get started. So we've had a bunch of pre-submitted questions that I will start with here. Let's see. So Dr. Wulffhart, since you're on camera, are you able to speak to the risk of the blood clots with the vaccine? Specifically AstraZeneca and Johnson & Johnson have been in the news a lot. Not sure if you have some comments on that.
So yes, I do have some comments, but just before I answer that question, if I can just answer that question about the diagnostic testing, because that's important. I don't want people to be under the impression we're doing tests just for the sake of doing it and occupying resources that are needed. Some diagnostic testing is important. For example, if a patient has severe aortic stenosis or a narrowed valve and requires surgery more urgently, they need a diagnostic test to facilitate the surgeons in knowing what procedure they're going to do, whether they need bypass or just a valve. So we can't avoid doing some diagnostic procedures to facilitate the final product or the final procedure that's going to be done. So some of them, although they seem to be planned or scheduled procedures, they're scheduled for a reason because they lead up to a more significant urgent procedure. So I hope that answers that question. In terms of blood clots, there are a lot of press around blood clots, and it's unfortunate that it gets so much press. And I think part of the reason is it sells newspapers and gets television programs a lot of ratings. There's a lot of things we do and medications we take that lead to blood clots, and I'll give one example before I get to the vaccines. But if you take the birth control pill, you have a much higher, it's probably around about 12 in about 12,000 in a million that would get blood clots as opposed to not. So the AstraZeneca vaccine has 4 blood clots reported in every million doses of vaccine administered. In the Johnson & Johnson, they have 6 people that got blood clots in over 7 million patients inoculated. COVID itself will cause 165,000 in a million blood clots. So getting COVID gives you a risk of blood clot, which is way more significantly higher than getting a blood clot from a vaccine. Everything we do in life has risk and benefit ratios, and you got to weigh the risk versus the benefit. We all drive cars. 12 in 100,000 people will die driving a car every day, and yet 3 in a million vaccinations causes us more hesitation to get a vaccination than get in your car and drive to work. So at the end of the day, we have to look at the proportionality of risk. Your risk of dying from a vaccine is probably 0.0004%. Your risk from dying from COVID is around about 16%. So, if you're admitted to hospital. So, although blood clots are being reported, I think that they're proportionately or disproportionately targeted in the environment that we're in right now.
Thank you. There's a question that was pre-submitted that's sort of like, what is the risk of taking this vaccine that, that it's too early, it hasn't been studied enough, it's come very quickly. Do you have any comments on that? Or?
So I can comment, I'm sure everyone can comment. You know, we were in a situation where we had to rush, and it was important to get a vaccine out to help curb this massive pandemic. Obviously, if we had time, we would have taken longer to do the studies, but there was no time. The technology and the research around vaccines is solid and clear and has been tested in other arenas and has proven to be effective methodology or technology. The fear is that it's been brought out very early, but already if you look at the research done to date, the positive outcomes already bear out that the research is appropriate. You know, one of the big myths, which I'll just touch on quickly, is the issue of how much immunity you get from the vaccine and how much protection you get. And without the vaccine, you have no protection. You may have a little bit if you've had lots of exposure to lots of other coronaviruses, but probably insufficient to protect you. With a single dose of the vaccine, if you put all the studies together, no matter which vaccine you use, you have at least a minimum of 70 to 80% protection, and with a booster up to 90%. And that's borne out in studies, even though they were rushed, even though they were done quickly, the data shows that it works effectively. So did we rush, or did the society rush? Yes. Would they have preferred to have more time? Yes. Are we confident that the vaccines work? I would say absolutely.
Okay, while we're on the efficacy of vaccines, there's a few more questions about that. Is Dr. Wulffhart the most appropriate to answer those?
I think
While you're
Dr.
up there?
Nathanson can take a turn and I can chime in if there's.
Okay, Dr. Nathanson. The Pfizer vaccine, there are studies that say that it's effective for 6 months. Do we know anything more about the duration of protection from the vaccines?
Yeah. So from the trial-based data that we have that led to the emergency use authorization and therefore the rollout of vaccines, from that cadre of data, and from the real world data that we have since the rollout of the vaccine and the uptake in the population, what we see is ever increasing levels of protection as time has unfolded, with no evidence of reduction in that protection over time as yet. It's still early days. There almost certainly will be a time at which point the protection factor will be reduced. It would normally be expected to be around a year for most coronavirus type vaccines. There is nothing that I'm aware of that suggests a 6-month limit, except maybe the initial data that only went to 6 months, at which point it's not as though the protection fell off. It was that people were being transparent in the limits of the knowledge we had at the time. Those who were inclined, as most of the people in my circle, professionally and otherwise, were inclined to take it, that's good news. It's onwards and upwards from here. For those who are inclined to interpret that differently and to use that information differently, it was touted as a limitation of the vaccination. And I think that was unhelpful, to say the least. But every bit of evidence that we have so far shows enduring and increasing protection from this and every other vaccine that we have developed and that's been introduced into the marketplace so far.
So do we know how much protection the vaccine offers as compared to how protected you are if you've had COVID in the past?
Mm-hmm. So the knowledge that I have from experts to whom I turn for my information would suggest that for about 3 months after a COVID infection, there is some measure of protection that's not complete, and it's probably not as good as, but certainly no better than the vaccine-based protection. As far as the vaccine-based protection goes, the evidence so far suggests that it is superior to natural infection, certainly after 3 months' time, when the protective antibodies are continued to increase, as I just described to you. So it's vaccine one, virus nothing on the degree of protection that's acquired after exposure to each. That's the best answer available today.
So it's better to get the to get vaccinated than it is to try to protect yourself by getting COVID.
So that is true. And I could tell you, being personal, that if I had acquired the infection, I would still have got the vaccine. I don't know that I would have waited the 3 months that was initially being touted, but I would not rely on natural immunity from having had the infection. I would get the vaccine. And as someone said on Twitter yesterday, I'd have it in my eyeballs if that was the only choice I had. So I would go to any lengths to get that vaccine under any circumstances, and I would apply that to any of the vaccines that are out there personally, for me or for my family.
Do we know that is the vaccine dosage effective on everyone the same? Like, does size matter? So larger people as opposed to smaller bodies, does it make a difference?
Right. So I'm going to leave the issue of whether size matters or not alone. I would say that there is no evidence that smaller people or larger people, it's good to see people chuckling on the panel. This is such a serious topic. It's always okay to chuckle a little bit. But there are folks who are less protected by the vaccine than others. And so those categories would be people whose immune systems have been dampened down either by disease or treatments, or as we get older, there is a diminishing in the immune response to all immunological stimuli. The same is true for vaccination. And there is some diminishing response to vaccine in the elderly. And we've seen that borne out in public policy as either in policy or in advocacy for different policy. We've seen the demands for the elderly to receive 2 sequential vaccines in a more timely manner than the 4-month gap that others have touted. So the answer is yes, but for most of us with intact immune systems, not belonging as Zaev and I do to the elderly population, for most of us, our response is essentially equitable across all spectra.
Thank you. Do we know how much protection one shot of Pfizer has? Or one shot of vaccine to Moderna, for example, as well?
Well, I see my little red live button, so I'm going to keep going until
go for it.
Someone else is going to take over here. So I think one of the things that puzzles me about the whole process, and I'd love to find one of the scientists who devised the initial studies to help out with this, is why initially 2 injections were used to begin with. Because most vaccines are a single vaccine periodically, and that's it. Occasionally, they require a booster years later. That notwithstanding, the evidence that's accrued so far suggests no limit to the amount of immune response and protection we're seeing to the first shot in the sequential vaccinations. And the further out we go and the more time-based data that we acquire, much of which is coming out of Israel right now, which leads the world in its vaccine rollout and its benefits of vaccine rollout, much of that suggests that even up till now, there's still increasing and no evidence of a diminishing in the vaccine efficacy following the first vaccine. So we're talking from the studies, it was thought to be about 50 to 60% after the first, just before the second shot. But in those patients, those people who have not received the second shot, we continue to see rising immune responses. No limit to that so far. And so as time goes by, we're seeing upwards of 80% and more protection in those 2-shot vaccines merely from the first shot on balance. Highly effective. And as Dr. Wulffhart said, no good reason not to get it that we're aware of so far.
Thank you. Another one for you then, I think. How do we expect these vaccines to keep up with the virus mutations? Does it protect now against variants of concern?
So the vaccine is intended to target a site on the spike protein on the virus coat. And that spike protein is quite well conserved across all the variants or mutations. Most of the mutations, almost all the mutations, namely the variants that are being reported, having been identified, involve mutations at sites outside of the spike protein, although there is one exception of concern. I don't know which of them. I think it might have been the one that was out of Brazil, even though I regret using the country name. I've tried, I can't remember the alphanumeric sequences. But by and large, these vaccines are targeted at the spike protein because the spike protein is so well conserved across coronaviruses. The mutations that we've seen, to repeat itself, the mutations that we've seen do not involve the spike protein. And therefore, by and large, with only a signal of concern, but nothing robust as yet, the vaccines appear to be equally effective against the variants. The concept of diminished effectiveness in the setting of a variant or mutation is called escape, or vaccine escape. And there is a small signal, but these come up if you follow the literature really carefully, these come up now and then they're disproved. Much of these reports come from media, that although the media are doing a phenomenal job in getting the truth out in most cases, some are not being as scrupulous about that, and some of them are highlighting areas of fear and risk that in overblowing those fear and risks, they have their own interests at heart. But I would say that by and large, overwhelmingly, each vaccine available is very highly effective and not yet a significant signal of reduction in the setting of the variants.
Okay, Dr. Thorne has joined now, so that's great. So we'll get to those arthritis types of questions shortly. While you're still up, Dr. Nathanson, there's still one here, but I think you could answer. If you have had COVID and you want to receive the vaccine, how soon after should you get vaccinated? Is there a minimum wait time, or can you do it as soon as you're symptom free?
So there are a variety of opinions on that matter. Different officials have different approaches. One approach, which carries a fair bit of weight, is never miss an opportunity to get a vaccination. And that is a very powerful principle. And I can tell you, if you take nothing away from all the yammering I'm doing on this podcast or this presentation, if you can take that axiom away, never miss a chance to get a vaccination, take that away from me. Remember me for that expression. On the other hand, there are those who would say that you have protection following an infection for about 3 months, and the need for the vaccination is less in the immediate 3-month wait of having an infection. And so if you are disinclined, hopefully for good and rational reasons, and not for poor and irrational reasons, to delay the vaccination, one could reasonably safely do so for about 3 months after the infection resolves. I would think that it's up to the individual to balance those two principles. And I think that I would trust that most of the people, all the people listening today, would be able to make a personal decision that suits them, as long as at the most 3 months later, you seek out and get yourself vaccinated and protected from this terrible disease.
Thank you. One more in the chat for you, Dr. Nathanson. Can we take it that you're a Trekkie?
Yes, yeah, you can. And the reason that's there is that there are times when I really would like to leave Earth. And if I could go to the space station and wait for this to settle down, I would. But I want you to know that I've made the decision. I'm going to stay on Earth and support my colleagues and my hospital and my community. And what I want is to look back upon these experiences this year, 2 years, 3 years, however long this lasts. I want to look back with pride on how I handled this, knowing that I contributed favorably and that I did my best to reduce the costs of the whole debacle. And I certainly would like to counter the voices that are causing harm out there with disinformation.
Thank you. Okay, so we're going to move to Dr. Chang now. There's been lots of questions about if you're pregnant and vaccines and fertility, so we'll get to those. And then we'll go to Dr. Thorne about rheumatology questions. So if you are pregnant, can you get the vaccine, Dr. Chang?
Mute.
Oh, you're muted.
Sorry. Okay. Yes, you can get the vaccine. So initially, we have a body called the National Advisory Committee on Immunization, and that's a national body. And when the vaccine first came out, they did not recommend that pregnant women get it. And the main reason for that is just like most drug trials or most vaccine trials, pregnant women are never enrolled. Like they exclude them. They do a pregnancy test before you get enrolled, and if you're pregnant, they say, sorry, you're not eligible. So the initial data, like if you look at the original studies before the vaccine was approved, did not include pregnant women. So because of that, the risk is unknown. Since then, we are getting real world data, and Pfizer also has started a study that involved pregnant women to look at the vaccine, to their response to the vaccine. Now, one thing you should know is we don't know, there is a theoretical risk to the vaccine, although we've given lots of other vaccines in pregnancy and they've been safe, okay? So this is not the first time we're giving vaccines to pregnant women. So the risk is theoretical, and really, they really don't really have and there's been no real world cases of risk with this COVID-19 vaccine in pregnant women. But the risk of COVID infection in pregnant women is known, and we know that well. And we know that if a pregnant woman gets COVID infection, they are more likely to get hospitalized, and they are more likely to get admitted to the ICU. So the risk of being hospitalized as a pregnant woman is about 8 to 11%, and the risk of getting admitted to the ICU is about 2 to 3%, and that's actually 5 times the risk of a non-pregnant woman of the same age. So we know that pregnancy by itself increases your risk of severe disease. So that's one reason why you might want to get vaccinated. On top of that, we don't know whether we don't know exactly why, but we know that the pregnant women who are infected have a higher risk of preterm delivery, delivering their babies early, whether it's from us obstetricians getting worried about them and inducing them, or whether it's a spontaneous labor, they have that risk. There have been concerns that there are effects of COVID on the placenta, and there have been reported stillbirths as well. So there are a lot of real risks to COVID infection in pregnancy. Now, there's a lot of chatter about, well, there's no data on pregnant women. Well, there was no initial vaccine data, but there's actually a lot of data. If you look at the US CDC, they've vaccinated at least 86,000 pregnant women, okay? And they have an app for women who are pregnant. They have an app that you download that like if you enroll, they have an app and they ask you surveys, and they've looked at least in the app, there's about 4,500 women in that app. And the last time they looked at this data, like where they analyzed the data on the app for these pregnant women that have been vaccinated, was March 1st, and they looked at over 2,000 women that were in this registry. And actually, the risk of miscarriage and stillbirth and diabetes and preeclampsia and growth restriction was actually lower than compared to national US rates. So as far as we know, the vaccine is safe in pregnancy, as with the data that we have so far. Now, our data is not perfect, and our data only goes as far as how long the vaccine has been, but the risk of the vaccine is theoretical, and we have real world data that says it's safe.
Thank you, that's very helpful. There's another one about infertility. So can you speak to the vaccine causing infertility, or do we know if it causes infertility? A lot of young female nurses who won't get vaccinated for this reason, which only puts them at risk. Do we know if enough testing has been done on this?
Yes, I can speak to this, and no, it does not cause infertility. That's the bottom line. So I looked this up because this comes up. So apparently the myth about this infertility came from 2 places. One is there's a movie called Utopia, where they created a vaccine for population control. And that's how this infertility myth has been propagated. And there was an epidemiologist in Europe that was questioning that the coronavirus protein has a little bit of similarity to a placental protein, and whether it will cross-react and cause infertility. So what I can tell you is the people in the baby business, the American Society of Reproductive Medicine, and the Canadian Fertility and Andrology Society, and the Society of Obstetricians, so it's in our best interest to have more babies, have looked at this, and there is no relation. This is a myth. This is a complete myth. So, and in fact, they recommend that women who are trying to get pregnant get vaccinated and complete their vaccine as soon as possible, so that they will be protected and their baby will be protected when they do get pregnant.
Thank you very much. That's very helpful. I think you have addressed all of those concerns that we have had pre-submitted. Let me just check the chat here and see if there's anything else that's come in about that. Yeah, no, you addressed it, so we're good. So we will move to Dr. Thorne then. Dr. Thorne, you're live. Did you want to do a quick introduction of your background?
I'm really enjoying this conversation. Barry, Genevieve, you've done a great job. I'm a rheumatologist at Southlake for the past 40 years or thereabouts, and quite interested in this. I was called upon by Steve Beattie and John Randall earlier last year to be involved in the COVID studies that we might be doing. So we're doing a few in-house as well as outpatient, so that's really great. I'm also involved at looking at the therapeutic committees related to COVID. And for our Canadian and Ontario Rheumatology Association, I've also worked with Health Canada in some what's called Tier 3 committees, looking at access, and this is particularly relevant for a medication that we use these days called tocilizumab. Previously it was Plaquenil when Mr. Trump was president. In any case, I think these are really a great opportunity for us to share those myths. As Barry so nicely pointed out, unfortunately, some people make money on sharing these myths. And I want to comment that it is really important that we understand context. So I wanted to illuminate or share some more information that Barry expound on it. The Israeli experience was really quite profound. Small country, relatively land mass, close population, lots of engagement, and lots of COVID at the beginning. They ramped up very quickly, as you all know, and really got the population covered off in the vaccination. And when they reached a 40% vaccination rate, their cases plummeted. And they have been relatively, and I think some people probably know better than I, but in a relatively normal social and economic environment since they got to the herd immunity of 40%, and now they're even higher than that. So getting the country into immune state is really important, including avoiding the variants showing up, because the variants show up as part of a natural selection by the viruses. So that's really important, I believe. Post-COVID, what we've also identified, as I understand it, is probably only one shot of whether it's a 1 or 2 shot. And if you've had a COVID infection, the natural infection, you get a super duper good response. So you really protect yourself and your people around you in workplaces. So you should be encouraged, as Barry mentioned, to get that vaccination. There's no reason you have to wait. Just wait until you're healthy again. And if at 3 months comes around, get it done. Make sure you're getting it done. And finally, in terms of what Genevieve said, we shared the same problems back in when the vaccines first came out. Our patients as well in rheumatology, the people with autoimmune disorders and on immune modulating, immunosuppressive medications, were specifically singled out with the patients with cancer, with the patients with other diseases, with the patients with pregnancy, to be left out of the trials. And in any usual trial, these patients are left out, and then they are excluded from use in the initial times until later on. Barry mentioned wondering why these vaccines were given at 3 or 4 weeks and why they're not given earlier. I think personally it's because they wanted to get the study done and wanted to get it ramped up, and if they had to wait the usual 3 or 4 months, then that would have delayed getting notice. So again, as a positive statement, look at the response we're getting at perhaps not the opportune time to give it of 3 or 4 weeks. So I think, again, people should be very confident about the strategy. Everyone, as many people as possible, to get vaccinated as soon as possible with your first shot. The second shot, anytime between a month and 3 or 4 months. And we're learning more and more about that. So strong recommendation there. So
thank you very much. Oh, we did have a specific question that came in about osteoarthritis that would be good for you to answer. So can the vaccine cause an inflammatory response in patients who have a condition like that? And should there be any concern regarding any doses? Do they take any precautions?
Yeah, another great question. One of the things we've learned, as Genevieve's pointed out, is real world data. That's really driven it. So there's a global rheumatology initiative, which is North American, i.e. Canada, US, some South American countries, and Europe have banded together. So all the national societies are contributing patients. We're getting our patients to fill out questionnaires and such things. So what we've learned, as Genevieve pointed out, it's almost a mirror image of what's happening in obstetrics. Patients who have autoimmune disease, I won't talk about osteoarthritis in a minute, autoimmune diseases are not more likely to get infected. However, like the pregnancy woman, if they get infected, they're more likely to have a more serious outcome. So avoiding the infection is really important. That's the vaccination. The next piece was, well, if I'm taking these medications that alter my immune system for rheumatoid arthritis or lupus, am I going to weaken myself and get some sort of infection? Again, very, very nicely pointed out, you are not getting the virus. You're getting the lick on top of it, and that's all you're getting. You're just seeing the thing that stimulates your immune system, so you can't get it. What we do learn is that individuals with the vaccine may get symptoms that feel like their disease, but it has not caused worsening of the underlying disease. It has not caused worsening of the underlying disease. You may get symptoms that mimic your disease, arthralgias and achiness and stuff like that. That's part of the deal. So coming back to the osteoarthritis, way back when I started, everyone took anti-inflammatories and you took it forever. And now that's not the case, whether it's osteoarthritis or inflammatory joint disease. There has been discussion about whether taking an anti-inflammatory may alter your body's immune response to the vaccine. So whether you should take an anti-inflammatory prophylactically with the vaccine to minimize the systemic effects, again, as Genevieve pointed out, theoretically it might be the case, but not practically. Practically, we don't know that. So in terms of osteoarthritis, no effect on the disease. In terms of the medications you're using, if you're using a regular anti-inflammatory, I'm not talking about taking it once in a while, but a regular use of it, there is no evidence that you are blunting your response. Some of our other medications that we use, such as methotrexate for rheumatoid arthritis, information from flu vaccine trials, and these have been done, these is real world, not real world, it's actual studies, indicate that if you're taking some of these medications that have a relatively short half-life, missing a dose or two is not going to affect your disease and will maximize your immune response. So these are all good news pieces of information. As Genevieve points out, pregnant, you can get it. Thinking about getting pregnant, you should get it. Rheumatoid arthritis, lupus, vasculitis, if your disease is stable, you should get it. If your medications are such, and it's usually prednisone, which is an offender, but it's doses of greater than 20 milligrams, which is not a common thing. Should you avoid, if you have a need for 20 milligrams of prednisone for your underlying disease to get it? Well, you should get it, of course. But as Barry points out, and others point out, as when the opportunity arises, you get the vaccine that's available that day. Don't worry about choosing the best one. They're all much better than most of the vaccines you've actually been exposed to in your childhood or adulthood. Just think of the original shingles vaccine. Zostavax had a 20% response rate. Shingrix is the 90%. These vaccines are giving you 67, 80, 70% after the first dose, and then you're ramping up to high 80s, 90% response. These are phenomenal. It probably represents the technology, presenting a very clean target for the immune system to be responsive to.
Thank you. Seeing lots of nodding with the other panelists as you're speaking there. It's really good information. There is a specific question here that I'm going to ask you. So I have a patient who has an autoimmune disease who is on biologic. He is told to take a vaccine and wait 2 weeks to get the biologics. My question is there a recommendation regarding timing for biologic and COVID vaccine 2 weeks after, or can they get it right away?
Okay, so that's another good question. The only reason for avoiding the treatment is to try and maximize the response. So that varies. We have medications that we use, leflunomide, for instance, which is just hangs around for ages and ages. There's no point in stopping that. Other medications have not been shown to have much of an effect, and now we come to the biologics. So some biologics are around for a very short period of time. So for instance, one called etanercept as the general name, actually has a half-life of only a couple of days. When it was first prescribed, it was given twice a week, and they made it once a week because it was a marketing advantage, because it was going up against Humira, which was every 2 weeks. So we try and give it between cycles. But again, to Barry's point, if you're getting, for instance, infliximab, which has its effect by giving you a whack load way high, and then it tapers over 2 months, you probably don't want to get your vaccine right afterwards. So I had this example. This person's on infliximab, gets it every 8 weeks. And by the way, his vaccination, his infusion date was last Monday. His dose date for the vaccine was Tuesday. I said, don't take it Monday, your infliximab. Take it a month later, so in the mid-cycle. So he's missed 4 weeks, but he's only missed 4 weeks. Then take it, and then take the next 4 weeks and get back on your infliximab schedule until your next dose. But that's all made up. There's not much evidence. And what we're trying to do is offer you a balance, as Barry pointed out earlier. Most important, if you just had your dose of whatever, of a biologic agent, you might want to wait a week or two and reschedule it, but you should not. I really strongly believe, as Barry does, get the vaccine in. You're only attenuating the response, you're not eliminating it, and better to get some immunity going. Especially when we see this very fluid market, sorry for the pun on drugs, this fluid market of recommendations that seem to change by the moment. I think what that really disconcerts people, the changing recommendations, and as Fauci so calmly placed it, we learn from this. We're learning from this, both locally in our own experiences, locally in our participation in trials, and internationally by looking at these larger registries. And we have to respect that sometimes our recommendations are going to change from time to time. And that's not because we were wrong. We were right for the information we were given at the time.
That's a good point. Thank you. Who would be best to speak to surgery and vaccine? There's a couple of questions here about that. Does anybody want to take those?
We have that as a question frequently in rheumatology because, whether the patient's got osteoarthritis or inflammatory joint disease, often they end up having surgery. And that's one of the endpoints, is avoiding surgery for our patients. Again, it's the same issues as what risk does taking any of our medications pose to surgery, to the infection rate of surgery. And again, surgeries are mostly clean events, right? It's a planned event. And we're not talking, the other kinds of surgery where you've fractured your ankle off, in a car accident, it's open wounds and all that's another story. But these are planned surgeries. So there are some suggestions again about holding methotrexate. There is no rationale for holding it. It's a belief, but there's no rationale. It absolutely does not increase infection risk. Biologics have also not shown to increase infection risk, except, and I should have given this exclusion for rituximab for the virus vaccine, as well as for surgery. Rituximab is a B-cell depleter, has an effect that lasts about 6 months. So if you just had a rituximab infusion for your disease, whatever it is, whether it's a lymphoma-related disease or an autoimmune-related disease, you probably should delay it. You might want to delay it. And we do that for surgery, try and do that for surgery and plan it that way. But by and large, these medications should not affect the vaccine should not affect your plans for surgical opinions. If you have an urgent need, you should have it done. If you're having it planned, hopefully you've already had your vaccine if it's being planned right now.
Right. And for a patient who recently had a transplant.
Wants to comment on that.
Oh, yeah. Okay.
The comment I was going to make with regards to surgery is that if you're COVID positive and you're having major surgery, you have a much, much higher risk of the surgery and a higher complication rate and a much longer prolonged hospital stay with a bad outcome. So if you're going to have surgery, you should have the vaccine to give you protection to not have these problems during surgery. The reason you get tested for your COVID status before surgery is to protect you as the patient, not necessarily to protect the staff around you. And so that's even more reason to get the vaccine prior to surgery and not get COVID prior to surgery.
It's good to know. Thank you. There's also a question about if you have recently had a transplant, so they're using a liver transplant as an example. Are there any risks? Like, when could they receive the COVID vaccine? Do they wait?
Yeah. So again, we are not really involved up here in patients who are having transplants. Remember that you can be a transplant that just had it, which is a different status than 5 years out. The person 5 years out is probably still on some transplant meds, but really it's at the beginning. At post-transplant, you're on high doses of prednisone, 40 to 60 milligrams oftentimes, for 4 to 6 or 8 weeks, again, depending on the circumstance and such things. And those are probably more important. So it really depends on the status, and I'm sure that the transplant physicians are proactively reaching out to those individuals. But you should assume almost universally that you're eligible, but seek out when you have these unique circumstances to inquire of the specialists in that area.
Thank you. There's a few more questions here about breastfeeding and the vaccine. So Dr. Chang, I think I'm going to put you back up for these. Okay. So do we have any real world data or recommendations on the vaccine and breastfeeding for women?
Yes, so just like pregnancy, they were not included in the original trials. We do know that, so the answer is yes, it's safe in breastfeeding. That's the bottom line. So again, what do we know? We know that this is a protein on the outside of the virus. It's not going to replicate. And in terms of theoretical risk, the scientists can't really come up with a theoretical risk of why this would be dangerous to the baby. Okay. Plus, we do know that when you get vaccinated, the antibodies are transferred to the breast milk, and that gives protection for other viral infections. That gives protection to the baby. So, and there has been studies that show that it's true with this virus as well. So actually, if you get vaccinated when you're breastfeeding, you're probably giving your baby protection against the coronavirus. So the answer is yes. You should get vaccinated while you're breastfeeding.
And how long should a person wait after getting an HPV shot to get the COVID vaccine? They say that my daughter lives in a hotspot, is able to get a COVID vaccine, but she got her first dose of HPV 2 weeks ago. Does this make a difference?
I think it's I don't think there's specific studies on this, but the expert recommendations to wait 14 days between vaccinations, and we ask that when we give the vaccine. That's one of the questions we have to ask is, have you had another vaccine in the last 14 days?
That's great, thank you. There was a few others that came in here. We did have a whole section we were going to do just on COVID-19 and treatment, but I see that we're getting close to time. So I don't know if we want to proceed or maybe save that section for another town hall. Arden, what do you think? Oh, you're on mute. Sorry.
Why don't you try and pick a couple of the most representative questions, and perhaps Dr. Nathanson or whoever is best to answer could tackle those.
Okay, let me take a look here. So I guess this keeps coming up, is how vaccination sort of changes our protocols for our procedures and how we treat patients, and you know, like, are we safe to gather with people who are vaccinated and that sort of thing. So maybe somebody could talk about how things change. Maybe Dr. Nathanson, you look eager. And you're muted though. Oh, you are on mute.
There we go.
Oh, there you go.
Very important point. In terms of the vaccination and its benefits, I just want to say that for me personally, and for the people who ask me and who maybe take my advice, I don't want anything to do with this virus. I don't want it in me. I don't want it anywhere near me. It's not because it's not because that it's dirty or bad. It's a risk that I don't want to incur for today and forever. And it's avoidable. So what do I mean? The vaccination gives us protection, we know this with great confidence, against severe disease. We can still acquire the virus, it can still infect us, and we can still transmit the virus to others around us, even with the vaccine and with maximal protection. Now, it is true that over time we've learned that there is some attenuation of the degree to which we acquire and transmit the disease, at least in some cases, post-vaccination. There is some attenuation, and we're still learning as to how much attenuation or reduced transmissibility there is. For now, I assume in my life that even though I've been fully vaccinated, I can still acquire and transmit that disease. And so I have made no change whatsoever to my personal conduct, the degree to which I protect myself in low risk or high risk situations, with one single exception. And that was last night outside, distanced, visiting friends. I actually let the dog lick my leg. That was it. That was the exception. And you just should have seen my wife. She went, "What are you doing?" It's a leg. It's okay, right? So that's my answer. So the answer is for me, and as a matter of policy, being vaccinated actually offers, it brings no difference in the way we protect ourselves from the virus. But let me just address briefly why one might think that we could conduct ourselves differently, aside from the notion that a vaccine should protect us, and that is the advice given by the CDC and Rochelle Walensky. And that's pretty contentious, but I understand it. So let me give you my understanding of why Dr. Walensky gave that advice, the new director of the CDC. My understanding is that there is such grave concern in the United States about vaccine uptake in the population and the ability of the Americans to achieve herd immunity, having paid enormous costs for the policies of the previous administration, that Dr. Walensky felt obliged to offer some benefit to the population who gets vaccinated. Otherwise, too many people were saying, why would I get vaccinated if it doesn't change my life? And so Dr. Walensky and the CDC offered a reasonable risk-reducing measure, measure to say, if you are with others who are fully vaccinated, we're going to be okay with you getting together. But those people who take that advice are still at risk of acquiring and transmitting that disease and causing other people illness and incurring whatever downstream results there might be from having that virus. And that's a risk that I'm not willing to take personally yet. And it's certainly not a risk that public health policy is willing to promote in our country here. So that's the full answer as far as I'm concerned. My advice is do as I do, and that is take every protection, do everything you can to not have this virus in you if you can. And that's my answer. Boy, you got me going on that one.
Thank you. That's very good. It comes up a lot in this third wave, the types of patients that we're now seeing in our ICU. Since you are in the ICU, can you comment sort of like what the average age has been this time around? So
in the first wave, so long ago, there was no doubt that we saw elderly people, mostly from congregate settings, and those who had other significant comorbidities together with exposure to the virus. And most of the deaths that we saw, not all, were the very elderly. At this stage, there is no question that in contrast to the first and the second waves, we are now seeing people who are younger. We have people now in their 20s, in their 30s and 40s. Not just sick and not just on ventilators, if that's not enough, but I mean struggling for their lives on ventilators and at the cusp of outstripping our ability to care for them and to keep them alive. We're also seeing folks who are sicker faster. Initially, what we saw with people were getting these flu-like symptoms, they were lingering in the community, they'd come into the hospital, they'd hang out on the wards for a while, and eventually they would trip the wire, so to speak, and we'd have to bring them down to the ICU and intervene. And now we're seeing people get symptoms today, and in 48 to 72 hours, they're not only hospitalized, but they're declining rapidly and they're landing in the ICU on organ support. Those are very big differences, and I'm glad that you asked the question. It's important because for natural and understandable human reasons, many of our younger members of the population felt dismissive of the virus, and I can understand that. However, those tables have turned, and the risks are much higher for those members of the population who felt protected at first. The risks are growing. The virus is getting smarter, and we're helping that virus in a lot of different ways, and we could go into a long discussion on that. But the virus so far is winning. Look at Ontario today. The virus is winning. And what I want is for the young people who might be listening, or for those of you who have an influence over the young people who might be exposed and who are wondering what should be done, they should take every measure and cease to see themselves as having any kind of protection that's age-based. The risks are going up every periodically. They're going up.
Thank you. We are at time. There is one more question here that I wanted to ask because we do hear this a lot too. Do we know what kind of studies are being done for those people who have had long-lasting COVID side effects or symptoms? So people who have had it, maybe they got it last year and still are experiencing these side effects.
Oh, it's me again.
Are you the best? Are you the best?
Well, I can give it a shot. I mean, so I am familiar with what's referred to as long COVID. That's the term that we've come to use. The fact of long COVID is probably the singular reason now that I advise that people do all they can still to avoid having this virus in them. There are ongoing clinical trials and studies. The focus hasn't been as strong on long COVID as really it should have been. I know that there are several sites in the States, one in particular in Manhattan, that is a clinic for long COVID patients, and they're studying them and and at the very least, they're giving these people a place to go and having clinicians give them at least the time and concern to try and mitigate the symptoms and track them and learn from them, which carries a lot of benefit in and of itself. So trials are ongoing, longitudinal trials. We're studying what's happening with these folks. We're trying to understand what's happening with them. They have typically constitutional symptoms, chronic fatigue, arthralgias, myalgias, boring from Dr. Thorne's world. There's no question that there are cardiac long-standing issues, boring from Dr. Wulffhart's world, with the inflammation of the heart that arises or the coronary vessels that arise from the acute disease. These things linger. It's a big issue, but in sum total, this whole massive topic of long COVID is a great reason to keep this virus at bay and to do everything you can to protect yourselves and to keep it away from you and the ones you love.
Thank you very much. Just one comment here I want to read. Please let the staff in our critical care areas know that we are all thinking of them. Thank them for their efforts, and we are all here to support them the best that we can. So I'll put Art in live to do a closing here.
Can I just make one quick comment? That's possible?
Absolutely.
I just wanted to say, there are two reasons that we want to get vaccinated, and the one is to protect ourselves, but the other is to protect our whole community and society as a whole. And as healthcare professionals, we've taken that oath, and I think we really need to honor that oath and do that. Once we get enough or sufficient people vaccinated, we get herd immunity. The quicker we get there, the quicker we'll get back to a normal life. So it's not only for your own protection, it's for everybody's protection. So if the only plea I make today on this town hall is please go get vaccinated so we can get back to normal life.
Yeah.
You'd be doing yourself and your community and your family and your friends a huge favor.
Thank you. Oh, you are muted.
You'd think that that would be an easy one after all of this. So here on that last statement, and we've got several options for people to get vaccinated. So please do take advantage of those. And I really want to thank our panel members for taking this hour of time out of their schedules. Everybody is very busy, but this information, this sharing of the facts is so important. And there have been several people in the chat saying, can we share this more broadly because the public needs to know, and we have been looking at whether we can perhaps post this on our external website. So stay tuned on that, but we're looking at how to do that, because I do think it is really, really important. And then that way, if you do hear some people who have some misinformation, you can direct them to this telecast. So thank you all so much. And for all you staff out there, I know that this is, it's hard times. It's hard to come to work. I really appreciate you coming to work. We need you very much. And our patients need you very much. And hopefully the more people who get vaccinated, the sooner we will get out of this. And as Zaev said, be able to resume some normal life, because I know everybody needs it, and especially those at the front line. So thanks very much, and have a good rest of your day.